Precisely 4 years, precisely 4 months after internship, I nearly killed a patient, and I didn't tell a soul. It was during the height of the AIDS epidemic in New York City, and our patients were dreadfully, brutally sick. In the midst of this, one night, we got this quiet, elderly gentleman with so-called altered mental status. You know, a touch of dementia, totally stable, labs fine, radiology fine. Our team was knee-deep in crashing, bleeding, infected patients. And so I knew I had to turf that patient stat. So I quickly transferred him to this other ward, one reserved for stable patients just awaiting discharge. And then we dove back into the endless night of raging illness. The next morning, I learned that my totally stable patient actually had an intracranial hemorrhage. He was bleeding into his brain. That's why his mental status was altered. But I missed it. I missed it because I didn't check the CT scan. Somebody said radiology fine, and I hadn't looked at the actual scan myself as I should have. You can't get much worse than missing an intracranial bleed. Luckily, a radiology resident had seen the scan, called neurosurgery, patient went to the OR in the night, and did okay. So in the end, this was a near miss. But I had still made the error. Had I discharged the patient home, this could have been a death rather than a near miss. I was horrified at myself for not having done due diligence for my patient. I was so ashamed that I didn't tell anyone, not that day and not for 25 years. As a fledgling doctor, I didn't really understand medical error. I thought of errors as aberrant events, defects that could be isolated and eradicated. And this idea of errors as anomalies, I think, sums up our current approach to medical error. If we just ferret out those incompetent doctors, slice off those anomalous actions, we'll be done. And the world will be safe for all patients to roam. I mean, how do we doctors learn about medical error? My first exposure was as a medical student at Morbidity and Mortality Rounds, the monthly conference for cases gone wrong. Now, I don't even remember what the case was that day, but the chief of surgery asked the resident who'd made the error to stand up in the back row. The chief looked right at the resident, and he said, "Well, I reckon y'all should have taken that patient to the parking lot with a rifle. Why even bother operating? Just shoot the guy already." The resident turned a ghastly shade of green, and for a minute, I thought she was going to be our next admission. But I was a student, and I was there to learn. And I learned, one, that I'd better do my damnedest not to make any mistakes as a doctor. Two, if I did make a mistake, I wasn't going to tell anyone, otherwise I'd be up there getting screamed at. And three, I might want to watch my back in the hospital parking lot. Now, I know this surgery chief, an excellent doctor, was trying to foment us toward perfection. But the message that we got was that anything short of perfection was failure. The current culture of medicine today is zero tolerance of medical error. Get rid of all medical error. Well, what exactly does that mean? If errors were committed by a small subset of doctors, the lousy doctors, we could simply escort them all to the hospital parking lot, and that would be that. No rifle even needed. But error isn't some foreign behavior, an adverse event. It's a regular part of our everyday human practice of medicine. Doctors and nurses, we make errors every single day. Luckily, most small, but error is intrinsic to normal human functioning. A typical patient these days walks into their doctor's office with a fistful of chronic illness to deal with. Diabetes, hypertension, cholesterol, obesity, heart disease. There's usually also an ache or a pain bothering them. There's often a psychological stressor affecting their health. Stress, financial worries, an aging parent. Then there are the screening issues. Mammograms, colonoscopies, vaccinations. And did I mention checking for domestic violence, HIV, mental health, drug use, alcohol use, sunscreen use, seatbelt use, safe sex, safe firearms, plus those 5 servings of fruits and vegetables that we need to make you feel guilty about? Just stop and think for a moment on the sheer number of issues that comes up in a typical doctor's visit. And each of these, each sprouts its own explosion of decisions about diagnosis, prognosis, treatment guidelines, medications, side effects, drug interactions, lab tests, insurance coverage, cost. Take a stab at the math. On an average day, a doctor spars with thousands of micro decisions. So, a good doctor bats what? 95%? An excellent doctor? 99%? That still leaves dozens of decisions that fall short. It's hard to call something an exception, an aberration, if it's happening to all of us all the time. But error is part of the fabric of normal human functioning. But the expectation by doctors, by patients, by society at large is perfection. When I think back to my error, missing the brain bleed, which for the record is just one of plenty of errors that I've made in my career, that error remained off the radar because it was a near miss, which is a ridiculous term if you think about it. It just means the patient was lucky. I mean, the tree still fell in the forest. But because I was too ashamed to say anything, that error remained forever hidden, uncounted, unstudied, unremedied, because of human nature, because of the profound emotions we experience when medical error occurs. Now, we of course have to acknowledge our beloved malpractice system, a tangible reason why doctors think twice before revealing their errors. If errors are part of normal human functioning, then litigation is precisely the wrong way to handle them. There are a host of creative alternatives out there, including no-fault compensation, something along the lines of the existing Vaccine Injury Trust Fund. But alas, they've only given me a short time this morning, so I'm going to have to leave the joys of malpractice for one of you guys to solve. To eradicate error, medicine has been told to take a page from the aviation industry. Here's hoping it's not the page on legroom, right, or customer service. But we have adopted some of their tactics: checklists before surgery, barcodes for patient identification, system fixes for look-alike medications. These are excellent starts. But these are the low-hanging fruit. The vast majority of errors never come to light. How can we fix them if we don't even know where they are? Shame, guilt, fear. You can't tally these on a spreadsheet, but they are the biggest elephants in the room when it comes to medical error. We need to recalibrate our thinking to accept that errors are part of our normal human metabolism in here, and not some unusual aberration out there. And then, our approach to medical error can be radically transformed. You know, we used to think of bacteria as the enemy, those disease-causing vermin best eliminated by the clean sweep of antibiotic. But now we have a more nuanced appreciation of the microbiome, the vast community of microbes that dwells within us, the good, the bad, the ugly. When it comes to medical decision-making, perhaps we ought to think of our behavioral biome, the sum total of our thoughts, actions, emotions. The vast majority of our decisions do fine, but a certain percentage will always fall short. But these are part of our native behavioral flora. To think of them as foreign is to misunderstand the nature of error. So, if we could accept that errors are indigenous to our behavioral biome, then our goal is not some impossible expectation of sanitizing away all medical error, but rather to gather this collective ecology and shift it in our patients' favor. Much like the evolutionary path of humans and microbes, our goal is to figure out how to live amongst our errors. We should, of course, continue to work on system fixes for common errors, medication mix-ups, dosing errors, forgetting to check the CT scan. But our efforts need to focus on the human elements that are the key to patient safety. Every one of those thousands of micro-decisions that a doctor or nurse makes every day is processed in our intellect. And these cognitive processes are highly amenable to the IT approach to medical error. Algorithms, checklists, standardized practices. But these thousands of decisions are also filtered through our underlying emotional network that hums steadily along within us and is the invisible architect of our actions. Tending to the emotional landscape may feel like a squishy, unscientific approach to medical error, but ignoring it will doom any medical error crusade. A central part entails undoing a toxic culture of perfection, one that prevents doctors from coming forward with errors, but also prevents patients and society from understanding that errors will happen despite our best efforts toward minimizing them. True perfection, if one can even use that term, is acknowledgement of imperfection. Without that, there is no way to improve. But this requires the fortitude to accept that errors are normal, the emotional courage to admit vulnerability. Things I might recast as a starting point for wisdom. It's easy to be smart, especially with technology to help us, but being wise is far harder. We tend to think of wisdom as here, in our intellect, but wisdom begins here, in our inner human core, in the tangle of thoughts, actions, and emotions. We just need to be intrepid enough to face this honestly. A good start might be for the top brass, the chiefs, the chairs, the deans, to speak openly about their medical errors, especially to doctors in training, but also to the public. If we hear from the titans of medicine that errors are a reality in medicine, no matter how diligent we are, no matter how foolproof our systems are, we might be able to redefine our definition of perfection. Patients are ill-served by an impossible ideal of perfection that gives patients unrealistic expectations, and keeps doctors and nurses from coming forward with errors because of shame, because of fear, because of the misconception that errors are anomalies. Patients, and that is all of us, have a vested interest in these errors coming to light. The best disinfectant, as both Florence Nightingale and Louis Brandeis observed, is sunlight. Everything and everyone functions better when you have enough light. Thank you.